Good afternoon, everybody, and thank you so much for booking onto this EDS UK webinar with anaesthetist and pain consultant Dr. Ravindran on pain management. And Dr. Ravindran, thank you for taking the time to join us and share your expertise with us today.
Thank you so much, Nikki, for having me, and good to be back. It's been 3 years since I last spoke to EDS.
It has been 3 years. We won't leave it so long next time. Just a bit of housekeeping. Everybody's on mute. That will ensure that you can all hear properly. We do have a Q&A session at the end of the presentation, so please do add any questions that you have into the chat function. If you want me to ask them anonymously, then just make sure you change it to hosts and panelists or choose my name. And I can ask questions without names so no one can see. And I'll do my very best to get through as many question topics as I can. The session is being recorded, but the recording is just myself and Dr. Ravindran only. And thank you so much for listening to that. And please enjoy the session. And Dr. Ravindran, it's over to you.
Right then. Well, thank you so much once again. And as is appropriate in these parts here, I've got a presentation to share. Just going to share now. Nikki, just do let me know if all of this can be seen. And let me just take this to slideshow mode. Great. Is that all right?
Lovely. We can see you and we can see your slides. There is a black box across it. I'm not sure if that's supposed to be there. Do you want to just flick to the next slide quickly and we'll just check that?
There a black box too?
Yeah. Across the top. It's gone. It's gone.
And it's not come back again?
No, perfect. Thank you.
Wonderful. Well, let's start off then. Right. Let me know if anything changes in between. And well, good afternoon. Welcome to, I see a few logins from different parts of the world. So good morning, good afternoon, good evening to wherever you are. So this is going to be a broader talk on where we are with pain management with specific reference to EDS. And more importantly, Nikki also asked me to cover a little bit on medical cannabis, and I'm going to be talking at it from a specific UK perspective. So that's what I'm going to be covering in this talk this afternoon. So for me, managing the pain in EDS is now much broader. I have certain qualifications and added skills, which now I feel needs to be more of a systems approach. We need to understand the patient in their entirety before we decide what kind of pain medications or options for treatment we need to give. As you can see from here now, my role has changed in a sense that I did start with my background in anesthesia, but I am a consultant in pain medicine. I worked in the secondary care specialist service in the UK for about 14-15 years. And now for the last year, I have stepped into working with some GP practices in Reading, and that's my role right now as a consultant in pain and lifestyle medicine. Along with it, I have some teaching responsibilities and help out as a visiting professor at Teesside and Reading University. And as I can say here, during my time as a secondary care consultant in the Royal Berks in Reading in Berkshire, I set up the community pain service and I set up the long COVID service. So I have seen patients with hypermobility, with EDS, with all these diagnostic labels presenting to me with a number of other diagnoses in my secondary care pain clinic, in my primary care, in my community service, when they're admitted to hospital for some surgery. And over time, I think I feel that I've had also the pleasure and the delight of supporting a lot of my patient peer supports in the Berkshire area with fibromyalgia support there. And as we know, we are understanding a lot more about what we thought were very entirely different conditions to now seeing shades of similarity. And that is all underpinned by a lot of understanding that has come through, especially in the last 4 or 5 years, as we understand the mechanisms of COVID, long COVID, and hypermobility better. I do have a few declarations of interest, meaning that I'm just doing a lot of things with all national and international organizations. But the main thing that's relevant to probably this talk here is that I work with Peak Health as a pain coach, and I'm part of the British Society of Lifestyle Medicine and Pain Society as well. But I love to talk about it. I've written books about it. I have a YouTube channel about pain science, about what we need to be educating other clinical healthcare professionals, but also patients in the understanding. And that's what my YouTube channel is essentially all about. So my talk today is going to be, as I said, focusing on our evolving understanding of hypermobile EDS and EDS in general, and more specifically, giving a flavor of what the new pain science has changed and what that means in terms of treatments, with a specific focus on medical cannabis. I think this is something that the work of organizations like EDS UK and so many other wonderful EDS specific organizations across the US, which have informed my learning as well. And so this is all something that's very common knowledge to a lot of you who belong to the EDS UK, that we are dealing with a multi-system disorder where there is connective tissue anomalies that are affecting different parts of the body. As far as we know, there are 13 varieties, of which 12 are definitely mapped on to some form of genetic change, which means that they are actually quite rare. The one variation which is very common is the one that is the hypermobility spectrum disorder, and the what's called the hypermobile EDS, which is the most common, which is probably actually underreported, underappreciated, underrepresented, and underdiagnosed. And I think that means that by the time people actually make the diagnosis, often they have to wait a few months, if not years, depending on which part of the country you are, which probable organizations are close to you. And what we're also realizing is that there is an overlap with a number of other coexisting medical conditions, and often patients end up getting those labels before somebody actually steps back and puts together this understanding of possible hypermobility. And I look forward to hearing from you in the chat on whether that's been your story in a way. These are just to keep in mind, there was at one point of time, we had a variety of labels, variety of organizations, and I must admit there's been a bit of chaos in how over the last 8 or 10 years in me supporting patients itself, I keep seeing these 3-letter acronyms and labels changing hands of different kinds there. Thankfully, there's been a little bit more uniformity since 2017 with the revised classification. And around the same time, there's been this international consortium for EDS, which has really tried to standardize how we communicate to patients, how we communicate between healthcare professionals on what we mean when we talk about different forms of EDS, what's rare, what's common, how do we distinguish, how do we diagnose. So with this specific one very common variant, which is the hypermobile EDS or hypermobility spectrum disorder there, we are finding data that now says that there is a very strong association. And this is, of course, coming from the international consortium really, is that there is functional GI disorder. That's important to remember there. There are now strong associations, and this is relevant for you to remember as I go through as well, is that we now understand that there's an element of stomach and abdominal issues, but these are functional, meaning that these are not due to any structural abnormalities within the gut itself, but it is in the function, the relationship between the nervous system that controls gut function and the immune system that is present predominantly in the gut and the intestine. They both are interacting to cause a disorder of function. So that's what is functional GI. We now the strong association between POTS and autonomic dysautonomia itself is a big thing after COVID that we understood. There's this component of what's called developmental coordination disorder, which is now realizing that this change that happens in the connective tissue is manifested as different forms of sensory as well as motor changes that can often present as dyspraxia, dyscalculia, dyslexia, and all of these are varying forms of coordination between sensations or motor. And of course, there's this talk about instability at the neck joints or atlantoaxial or craniocervical instability due to the connective tissue, which has a different set of symptoms and presentations as well. And there's a strong association with mental health issues, which, for example, anxiety, depression, and a variety of other psychiatric disorders there. There is data that's coming through that there's evolving association, meaning that conditions like interstitial cystitis, a variety of other bladder issues or uterine issues, dysmenorrhea, hormonal imbalances that might cause a variety of, especially in women's health, problems in that space. This overlapping understanding of neurodivergence and autism-related hypersensitivity disorders or attention deficit disorders, traditional classical ADHD, and then this sort of spontaneous drop in blood pressure, which can manifest as headaches as well. And finally, this association between the immune system and the nervous system. Now, even in traditional pain literature, this was not appreciated until 8 or 10 years ago, but now we understand that in chronic pain of any kind, persistent pain of any kind, there is a strong influence and bidirectional communication between the nervous and immune system that has got implications. And within EDS specifically, there's an interest in one type of immune cell, the mast cells, whether they become overexcitable, they release too many chemicals, is there an intolerance, is there a histamine intolerance? These are all still evolving phases of research, and some researchers don't appreciate or don't understand. Some of the clinicians feel it is not relevant, but watch this space is all I can say. And indeed, there's a lot of work that has come through, especially from researchers like Jessica Eccles in the UK and a number of other researchers in the US, who are bringing this link together of how the brain and the body, we need to be thinking. I mean, I think everybody appreciates that the brain and body cannot be separated anymore, but the data that, joint hypermobility links the neurodivergence like autism and autism-related DHD to dysautonomia, or whether there is a variation of connective tissue to fibromyalgia and ME and CFS. All of these are studies that are coming out in the last 4 or 5 years that are now making us really rethink this whole possibility of number of the conditions that where we used to think that people can have 3, 4 labels, maybe there is some underlying change happening overall in the nervous and immune system that seems to present in a spectrum way. So for example, where we right now are, and this might change in the next 3 years that I give this presentation, I just noticed that actually I've still got the header and footer still from the old time there, but all of these are updated slides. And effectively what we are saying is that there is 7.5 times more common or occurrence of hypermobility with autism. There's almost 5.5 times more link with ADHD. There's 3.5 to 4 times more likelihood of fibromyalgia or chronic fatigue symptoms. In females who have got ADHD or autism, there is an 80% chance of hypermobility happening. Jessica Eccles presented research showing that there's a 30% more chance of them being left with long COVID or having long COVID as well. And we realize that the sensory processing is changed. When the connective tissue is changed, it not only affects how we walk or talk, the motor, it obviously affects the second part of the nervous system, which is the autonomic nervous system, causing dysautonomia, but it affects the sensory part of the nervous system. And pain is a sensation. Yes, you might say it's an emotion as well, but it is a sensation. And therefore, if you can have sensory processing issues happening with touch, with how we appreciate pressure or touch, then pain is also affected in the same way. We know that patients sometimes with hypermobility or extreme changes can be very sensitive to light, to other forms of noise. So there is auditory processing, there is visual processing, there is sensory processing. So pain also changes in the same way. And during my 15 years, both in secondary care and primary care in the UK, I've seen patients come to me, male and female, presenting with a wide variety of pain symptoms. I've seen patients with axial spine pain, specific localized areas of rib pain, or abdominal pain, or pelvic pain, to instability, headache being a problem, TMJ, temporomandibular joint dysfunction, all of these. So it's been a widespread pain picture that has come through. And I'm going to give a little bit of an overview in here with regards to pain in EDS. is that there are multiple causes. We haven't, and in my time of looking after EDS and hypermobility patients, I really can't pinpoint to saying that this is the only reason. I have to say that right now, the elasticity in the connective tissues may be one factor. We're understanding that when the immune system is affected, or even when the connective tissue is a bit stretchy, the change in the immune system that might occur due to an infection or a virus or a surgery or some kind of threat response can induce changes in some of the immune cells. And those immune cells can release inflammatory chemicals or cytokines, which then on a vulnerable, slightly stretchy tissue can then change the way the tissue is modified, and that can make the stretchy tissues even more of a problem. That is one thought that is bound to be now influencing research. Obviously, it's possible that if people are very hypermobile, is there a possibility that the cartilage thins out a little more quicker, and therefore the arthritic changes are seen quicker? Again, arthritis itself is now not considered a wear and tear, but a wear and repair process, meaning that throughout our lives, the changes that happen in the cartilage is a process of constant wear and repair. If there is the possibility that more wear can occur than repair, and that balance is lost, is that where you start to see pain starting to happen, because the amount of wear is more than the amount of repair. Obviously, when you are moving less and you're in pain, is there a secondary deconditioning effect and the muscle strength or muscle bulk or tone getting reduced, contributing to a pain there? The conversion into fatty tissue and storage of fatty tissue, and we understand that in some populations, some kinds of fat will start to release chemicals called adipokines, which themselves will be inflammatory there. And ultimately, dysautonomia in its widest presence, when the autonomic nervous system gets affected, that has a widespread range of impact, which we're still understanding, and we are trying to look and see how it can make an impact on a variety of other sensory processing. Is that then contributing to the pain? All of these, as you see, are complex, they are overlapping, they are related, and they do confuse issues then in terms of treatment, because often in the NHS and probably worldwide, the medical system is often geared up and ready to treat single problem, single system, where everybody thinks they understand the cause and effect. Something like EDS, where the overlap is so many, like the way I've talked here, it does make it challenging. So this is where I'm on a mission to actually raise awareness to say, what is now then the changes that have happened in the pain science, to say, can we and should we think a little bit differently? And does that give us then a little bit a wider set of options to manage pain, not just in EDS, but generally? First thing, some of the knowledge that has come through in the last 10, 15 years of understanding neuroscience. For example, the story that I often talk about in my talks that I give is, this was a case study that was published in the British Medical Journal. This was something that was done. Actually, the study was in 1995. And this was a builder who jumped off a platform and had this almost 2 to 4 inch nail go right through the boot, as you can see the picture on the left side of your screen. Oh my God, he was in absolute agony, could not be controlled there, writhing and moving about, and had to be taken in the ambulance. Even in the ambulance, he just couldn't respond to gas and air, and so he was brought into A&E. In A&E as well, small piece of sedation, he wouldn't keep quiet. So the decision was made to take him to theatre, get him off to sleep, and the surgeon was all ready. The anesthetist had got him off to sleep, and the nurse then pulled out the nail, took off the boot, and they got ready to clean the wound. And what did they find? No sign of physical injury. Effectively, the nail had probably passed between the big toe and the second toe, and there was no physical injury for the surgeon to clean. Looking at this picture here, do you think the patient was making his pain up? Probably not. But this is where, and multiple studies like this have helped us establish, and I can go into it in more detail as well, but effectively we are in a position where we can be fairly confident in saying that the degree of intensity of pain that you feel will not correlate with the amount of injury or structural change that is seen on a scan or imaging, or sometimes as you see in this visual picture. That's the first thing. There's no correlation at all between how much pain you feel and whether that's coming from a joint that looks arthritic or not. The second, this is an interesting study which again has been done in many fashions and forms. So this was among university students. The study was done in Australia. And in this study there, they took a bunch of university students, divided them into two groups. One group was shown a red light, another group was shown a blue light, but both groups were given a stimulus which was extremely cold, a minus 20 degrees iron electrode placed on the back of their hand. So effectively, they were feeling the same biologically intense signal, minus 20-degree electrode. You can see how that cold that would be. But one group of students received a blue light when that signal, one group of students received a red light when that same minus 20-degree electrode was applied. And on the right side of this image here, you're seeing the pain scores of both those people. And the red light scores, as you can see here, on average, all of the lines and the pain score was much higher when the red light was shown as opposed to a blue light. Why is that? Well, the understanding and what the researchers said was that in society, we've always considered, and right from young age, everybody appreciates that red is a sign of danger. And so the brain automatically felt that even though it was the same minus 20-degree electrode, the red light was considered to be more intense. So context always matters. Context is so important when thinking about the intensity of pain as to what else is happening around the ecosystem and environment of the person when you have a certain painful signal. The third kind of thing when going into context and taking this one step further is an interesting experiment done about 10, 20 years ago. And this was published in 2003. And effectively, this was looking at rejection or isolation. And they had a very narrow, in this, the researchers took a human participant, put them into a machine, an MRI machine, which was looking at the way or which parts of the brain light up when you feel rejected and when you feel isolated. And this was called cyberball because two computer bots would be playing a game called cyberball. When the human participant is included as part of the game, the cyber bots pass the ball to the human participant. And then at a predetermined time, the researcher would flick a switch. At that point, the human participant would be feeling rejected or excluded because the cyber computer bots would stop passing the ball to the human participant. So the researchers were seeing which parts of the brain light up when this human participant felt rejected. And to their surprise, and this has now been proven in many experiments like this in the last 15 years, that the part of the brain that lit up when this person felt rejected, excluded, isolated, is the same part of the brain that lights up when you have a physical injury, a swollen joint, a surgery, an injection, an operation, a fracture. The part of the brain, the parts of the brain that light up and the circuits that light up are the same when you feel excluded. So as far as the brain is concerned, and remember, we have not even taken in the variety of other isolation and loneliness inducing stimuli we have in society these days. Work pressures, the diminishing social support, life context as we age, loneliness as we go on, COVID related problems, and the political dramas that we see around us. Take all those into account. What we are finding and wanting to say is that as far as the brain is concerned, we and the brain and the body has never been able to distinguish between the brain and the body. We in society have artificially classified this is physical pain and this is psychological pain. The brain has no such division at all, which is very important in terms of how we approach treatment. And for me, that's very clear, and this has now become part of the new guidelines as well, is that physical component of chemicals being released and the chemicals becoming biology, for example, that minus 20 degrees electrode of cold feeling or extreme heat or a chemical gets converted into an electrical signal for the nerves to then take it towards the spinal cord and the brain. That first part of chemical heat or touch or injury getting converted into an electrical signal is what's called nociception. That's a very narrow part of what happens. That signal, then when it reaches the brain, undergoes a lot of context undergoes a lot of processing, undergoes a lot of prediction to say what happens to the signal. What was I doing when the signal happened? Am I right now in a safe place? Am I right now on a football field about to score a goal? Or am I in the middle of a street about to be run down by a bus? The same ankle twisting injury, the nociception, is going to have a different outcome based on the context. And the brain does all of this thinking and quickly processing. And if it decides it wants to bring about protection, that is when it will bring about the experience of pain. So that is why pain and nociception are not the same. And this is very crucial in terms of how we move forward with treatments. And I'll come to that later because you might have been thinking, well, what is this processing and prediction? Let's just explore it a little bit more. When you have that signal, whether that's an EDS related stretchy joint where you feel the sudden pain coming on, but there's no swelling, or whether you have suddenly a flare up of pain that happens, ultimately we are saying that, okay, you may have a site of injury in the periphery, you may have some signal coming from there to the spinal cord, which is the first junction box and the relay box. That junction box will send the signals to the brain, but the brain engages. And this is crucial because in the 80s and 90s, we were just taught, and by me, I mean we as in healthcare professionals, we were taught that, oh, the signal has come, there's a gate control theory, there's a gate in the spinal cord which allows these signals to go, and the brain would then react to these signals and say, yep, this is what we need to do, pull the leg away, pull the hand away from the source of injury. What we are now saying in pain science is that actually when the signal arrives there, the brain and the nervous system, and indeed even the parts of the body, has already got a prediction model of what to do in various contexts. It already creates a model ready to protect you in advance. So when the signal comes, the brain is saying, well, is this what I expected? If it is not what I expected, do I need to protect? If I don't need to protect, shall I just ignore it? If I need to protect, should I bring about the experience of pain? And right now, when I'm telling this, you should be asking yourself the question, where is the brain making up all of these predictions from and where is it storing it? Well, it's stored throughout the entire memory circuits in different parts of the brain and the body, but the prediction models are coming from a variety of stimulus over the lifetime of the patient. It can be an internal sense of information that can come from the gut, that can come from various viruses, bacteria, infections that happen throughout childhood and adulthood. It can come from external influences that can be the immediate body injuries. It can also mean the immediate societal parts that you see, things that you learn from your friends, from your family, from your parents, from your culture, from your society, from what you read in the paper, from your influences. All of that forms the external input to your prediction models. And we are now realizing that there is also the implication that if your nervous and immune system, when they are developing in childhood, have been exposed to persistent, intense, adverse stress, that also can set the stage for prediction models to be learned. And this is something that came out of the work in the 1990s called the ACEs study, where a group of GPs in San Diego asked these 10 questions around abuse, neglect, and dysfunction to their GP surgery participants. And they found that when you had 4 or more adverse childhood experiences before the age of 18, it impacted on how your nervous and immune system developed and manifested throughout the adult life. Indeed, by that sense, what I'm saying is the data is now there to say that when people have had 4 or more such experiences and they have not had a resilient adult to look after them or support them and calm their nervous and immune systems down and give them safety and protection, then a variety of physical health conditions also start to manifest. For example, on the left side of the screen, you can see cancer, heart disease, diabetes type 2, stroke, respiratory problems, liver problems are all increased when you have adversity that hasn't been resiliently supported. And we are now realizing that in chronic pain, this was a study published just 2 years ago, where they looked at more than 200,000 participants over 68 studies, 15 different types of childhood adversity, different kinds of chronic pain diagnosis. What they are saying is that there is a strong association. Just as I told you earlier about strong association of EDS with a variety of functional GI conditions and everything, there is now a strong association between having significant adversity and lack of resilience to presenting with chronic pain in adulthood. And so all of these changes that have come, and I've not even talked about chronic pain and microbiome and nutrition and all that, but all of these are now making us understand that we need to think about persistent pain, not necessarily as a response to a ongoing structural problem. No, not just a body issue, but it is about pain being looked at as an ultimate protector. It's there to protect us. It is giving us an indication that there is something it's trying to protect us from, and we need to widen our lenses from just the body to actually looking at the person as a whole. And this is the brain and the body coming together. The decision maker and opinion giver may be the brain and the nervous system, but is this the body that is also getting involved and it's sort of embodied, asking the question, what is the threat? Where is the threat? What do I need to do to protect to this person? And just to make it clearer, there are changes, and I'm not saying this at a psychiatric or psychological level. We have now the evidence from various studies, human as well as animal studies, to say that these pain processing circuits in the brain have some change. There's still questions being asked whether there's something around genetic, but there is definitely change in the neural circuitry of a variety of kind. That means there is increased pain processing and amplification. It's happening in the brain. It's happening in a form of what's called neuroplasticity. The same neuroplasticity is happening in the spinal cord level. And when you have these kind of changes in the nervous system and immune system, making the whole system much more hypersensitive and looking out for threat, looking out to protect you from everywhere, this kind of pain has a new name. This is called central sensitization or nociplastic pain, and the NICE guidelines in the UK have also been calling this chronic primary pain. Very relevant because there are now studies saying that central sensitization is probably the mechanism that is what is happening in joint hypermobility or Ehlers-Danlos, the hypermobility type. There are studies coming through various parts here talking about central sensitization in a variety of chronic pain conditions. And basically, we are right now at this point where we are saying that one of the main mechanisms for pain in EDS is due to central sensitization, the overall activation of the nervous and immune system. And that has relevance because we now are being taught in medical school, in pain schools, in GP schools, in various healthcare schools. That's at least what I'm doing, teaching around, is that we've traditionally taught about one kind of pain that happens when you have injury or surgery, and that's the nociceptive pain, what you see in the yellow circle in the top left. This is where medications like your opioids or your anti-inflammatories or your codeine will work. If you do injections or surgeries or infusions, it will work for this kind of pain. You may have sometimes a neuropathic kind of pain where you have nerve injury or nerve damage or trapping or surgery where nerves are cut, or things like diabetes or a stroke or Parkinsonism where nerve is, the system itself is damaged. That's a neuropathic pain. And sometimes you have some kinds of surgery, some kinds of interventions or medications, nerve medications like gabapentin, which could work. But this third category, this nociplastic pain, where the nervous and immune system has got sensitized, which I told you could be happening in EDS a lot more commonly than you think. Unfortunately, at this time, we don't have the traditional medications we give in GP practice, in hospital practice, do not work very well. The interventions, the injections, the nerve blocks, the steroids don't work very well, and the evidence is not great. And as I told you, this is what is chronic primary pain or central sensitization. And the data is now coming out to say that up to 1/3, 30% of people who start off having a surgery or injury could become nociplastic. The nervous and immune system can get sensitized in a third of these patients. In neuropathic pain, it's even more. It's 66%, almost 2/3 of people will start to get nociplastic. So a dominant question is oversensitive nervous and immune system is occurring in most chronic pain. And this is what has prompted in 2022 for the NICE guidelines in the UK to itself change in how we assess chronic pain. But the second part of this guideline was specifically to manage chronic Primary pain. Remember, chronic primary pain is this third new category called nociplastic pain. It's not some other form of chronic pain. And this is important because the examples you can see here on the right of what are the examples of chronic primary pain and are they relevant in EDS patients? Well, fibromyalgia, I told you, 3 to 4 times more common in hypermobile patients. IBS, functional GI disorder, more common in IBS patients. TMJ pain, migraine pain, more common here. Primary MSK, axial low back and neck pain, more common here. Some forms of CRPS. So you see, 5 out of the 6 categories of chronic primary pain are also what gets sometimes misdiagnosed, overdiagnosed, while patients are having hypermobility-like features. And that's why I need to necessarily zoom out. And at least that's what my practice is now, is that if I have to now take in these new concepts of what I know about pain and actually say, well, what do I now need to do for managing and helping people manage a pain, is not just focusing on what drug or what pill or injection I need to give. It's about saying, well, what is this person's overall background, context, vulnerabilities? Everything needs to be taken into account, the social determinants of health. And then I have the pillars that I can do, but I also then need a team around me to actually help people make that change and sustain that change, because changing those ways, those neural circuits, those neuroplasticity is not a one-off quick 1 week or one lesson or one topic or one drug fix anymore. It takes time. It takes working with the person. It takes time to build a new circuit. It's almost like you're creating a new habit. And you know that when you want to create a new habit, how long it takes for it to become second nature and daily. So the first part is, of course, the attention to the social determinants of health. And that's because, and that's kind of what's also prompted me to move from secondary care, specialist care to work in primary care, because then I can help in connecting the dots there. Because what I do in healthcare, sitting in a secondary care service or even sometimes in a GP, is only 20% of what it means to the well-being, to your well-being, to what it means to your quality of life. The remaining 80% is comprised of a variety of factors that right now is not under my awareness. And if I am not aware and cannot make a difference to it, then I'll only be supporting 20% of your return back to quality of life and not making much impact in the remaining 80%. And that's kind of what I write about in my book as well, is to say that, yes, there is a role for medications in EDS. There is a role for some interventions at appropriate times in EDS and hypermobility. But let's talk about how we get the other 5 elements, the interventions, the neuroscience, nutritional strategies. How do we optimize for sleep? How do we optimize for movement? And how do we optimize for mind-body techniques? Because when it comes to this thing that I told you about, this distinction between nociception and pain, my medications and interventions will work well for the nociception element, where there are chemicals being released due to an overstretchy tissue releasing chemicals, or there is an injury or a fracture or a surgery. But for the pain experience that the nervous system and immune system is doing because it's responding to threat, I need to think of other ways of calming the system down. And that's what I mean by a more joint-up approach. And the reality is that the existing medications that I have work in only a third of patients, as I've told you before. Even when I do steroid injections for hypermobile patients there, it works well, but I can only do it as an enabling to rehab. I can't depend on it as the cure-all if I haven't addressed the other parts there. I think this topic, you might understand and feel that there's a lot of new things you're learning, but you'll be surprised that a lot of pain specialists also are not even pain specialists, other healthcare professionals are not aware of this new pain science. And the reality is, if you go about meeting doctors and physios and healthcare professionals to help you with your pain, they totted up. Somebody did the research and totted up that at the most you would be spending 5 to 10 hours of your time looking and meeting these healthcare professionals and getting advice. It's important to then say, well, what are you getting the confidence, the skills, the knowledge, and the ability to do for the remaining 8,750 or 55 hours in a year when you're going to be with yourself, with your family members, with your friends? How can we as healthcare professionals give you the confidence, the skills, the attitudes, the knowledge, the reassurance to manage those times by yourself? And that's important. And that's the ultimate question I ask in EDS, in hypermobility, for that matter, a lot of persistent pain, is that we need many ways to tackle this problem. So medications and interventions are good. And right now in the NHS, they are probably the easiest and the quickest to get. But we need to think about the other 5 things that I talked about and say, well, how can we make these more accessible, more easy to do, more appealing to do, more as a group, maybe? And that's what makes me interested. How can we help people maybe do it as a group? Is that more sustainable? How can we harness neuroplasticity? How can we help you build those new habits and skills and routines that you need to become more comfortable in managing the pain? And we're realizing that sometimes flare-up management is more a question of how to do it rather than hoping it won't happen. Is about giving you the confidence to say, this is how I manage this flare, this is what has happened, this is what we need to do in terms of relaxation, activity, and distraction. So bringing all this together, where are we right now? What are the techniques for managing it? What can we do? A lot of these on the slide that you see are various ways that I use to help my patients with hypermobility, EDS, variety of persistent pain, for a variety of interventions and conditions. That's what my day job is. And I have a team of colleagues who help in various bits of this. I'm aware of all of them, and I think that raising awareness itself is a big piece. But I'm going to focus on one group of medications, which right now is creating some awareness that we could potentially use this group of medications, which specifically the cannabinoids. And I think it's still evolving times in the UK. Certainly things have changed in the last 4 or 5 years. But just to bring you up to speed, and I know that a lot of you may have already tried it. If you're from the US or Australia, you probably are already on it there. But my view is that we have a lot to understand about medical cannabis. I have had a complete sea change in my understanding as I've trained in it and now a prescriber, is that we are seeing that medical cannabis is now being used in so many different conditions. Chronic pain is just one of them. There are studies now talking about its role in different parts of the brain, in mental health issues, in neuropathy, in conditions like asthma, in HIV, in a variety of cancer-related conditions, infection, inflammation. Indeed, the first thing to understand about it is it's not some kind of horrible drug from the outside where there's a lot of stigma. We have our own endocannabinoid system. We've been making this stuff, ladies and gentlemen. We make our own stuff. And in our pharmacy, this is called the endocannabinoid system in our body. We actually have got receptors ready for it, have always had, ever since the humans have evolved. We've had receptors for the cannabis that we produce inside ourselves. And these receptors are present throughout the brain, throughout the immune system, in every organ of the body throughout. They are present. And what are they doing there? They essentially regulate what's called homeostasis. They are responsible for bringing in equilibrium. If the fight and flight system, your sympathetic system is fight and flight, or your parasympathetic and your vagus is rest and digest, the cannabis system is the one that brings the balance and the harmony back into both these other systems. They're not only responsible for that homeostasis and balance, they do a whole lot of things during delivery, childbirth, pre and postnatal development, for appetite, for pain sensation, for mood, for memory throughout. And indeed, the 2 receptors that have been identified now are this one called CB1 and CB2. There are 2 different kinds of 2 drugs that have been identified. Not drugs, sorry to clear. They're not drugs. These are our internal cannabinoids. These are the molecules that we produce ourselves that act on these receptors that are present throughout the body, giving us the benefits that we get. I'll go to the story if we have time later, but these receptors, as I said, are present throughout the body. These dots indicate to you where in the human body these receptors are present, and you can see they're present in the head, in the spinal cord, in the nervous system. They are present at each and every part of the nervous system in the slide there. So that is what we are doing when we are taking a cannabis from the outside. They're already acting on receptors that are there for our internal cannabinoids. We've just created an extra bit on the outside, and we found that the plants are there that act on these. And right now, the data is still evolving. We think that there are 9 big picture cannabinoids. THC and CBD are just 2 out of the 9. There are 9 big picture players that are there in a whole flower. The big ones are THC and CBD. Alongside these 9 cannabinoids, there are a whole lot of other many tiny chemicals, up to 60, 70 of these chemicals called terpenes. There are names like limonene, which gives the lemon, the pinene, which has a pine smell, ocimene. All of these are responsible for the various smells that you have when you smell cannabis on the roads there. Those are the flower things. Those are all the terpenes. And we think that they do cause some kind of contributory beneficial effect called the entourage effect. That's still being studied there. There are different ways of delivering the cannabis, and I can go into it during the Q&A. But right now, the CBD that is present both as the medical form and sometimes in the health food shop there, they can come, and I'm going to focus on the medical cannabis side. When you have CBD preparations, if somebody tells you it's full spectrum, it means it has got less than 0.3%, or it's broad spectrum, which means nothing at all, or just the CBD isolate, which just means only CBD. These are just different ways of getting purely the CBD part as medical cannabis. Now, for hypermobility, I looked through the data a few days ago. There are a few studies, qualitative studies, registry-based studies, observational studies, but we don't have full-on awesome randomized control high quality evidence at this time that cannabis is specifically best beneficial for EDS, but certainly helpful. And my present status, I would say, is that what you get in the health food shop has not really been put to proper medical scrutiny. So they may be safe to do, and I have some suggestions that I make to patients, but I can't comment on them anymore because they are not have any studies to back them up. The medical cannabis that's been approved in the UK as of 2018, it's still unlicensed. The only licensed versions are 3 drugs for 3 conditions. You've got nabiximol for the MS-related spasticity. There has been a drug, a kind of cannabis that's been approved for childhood epilepsy, rare ones. And then there's a drug that's formed that has been approved, Nabilon, that has been approved for chemotherapy-induced nausea and vomiting. These are the only 3 things that has been licensed and approved in the UK. But you have a variety of online clinics, and if I had to make one suggestion of where you could go to go down those rabbit holes safely, then I would suggest this thing called medbud.wiki, which is really helpful, very UK based. You can look at it, all the 4 devolved nations as well. There's appropriate evidence based on that. There's really good quality stuff going into cost, everything included in there. I did a couple of videos 6 months ago, specifically on YouTube, looking at the way medical cannabis should be thought about and moved forward. I didn't do it with a specific for EDS, but you're happy to check that out. And my practical takeaways, if some of you wanted to think about it or have been thinking on it, and if you're already on it, I'd love to hear from you in the chat sections in the Q&A really. My suggestion to patients as well as to my clinician colleagues when I'm giving talks is start low and go slow, because EDS patients are especially sensitive to medications. Monitor closely for side effects. Use them as adjuncts, not as sole drugs there. And go for formulations that allow for some flexibility and titration, oils rather than less flexible ones. Vapes are also all right. There is some definite caution in specific rarer forms of EDS because of all those other risks there, but the data is not very great. And because we still don't have good enough guidelines, I would suggest that whoever is doing it, document very clearly. Even if it's a patient doing it, document very clearly what is the benefit you're getting, how long you're going to take it for, what you're doing for. And especially when I'm talking to patients, I think it's very important to manage expectations and be very transparent about it. There are some other organizations looking at supporting patients with EDS through variety of stories of recovery, where people are recovering using a combination of these techniques, combination of retraining the nervous system using other sets of approaches. These are recovery stories. These are stories where essentially I use these stories to infuse the bit of hope, because often by the time hypermobility and EDS patients come to me, they've already had their diagnosis of EDS quite late, 1, 2, 3 years down. And then by the time they come to a pain clinic, it's another 2 or 3 years down the line. So often they're quite feeling helpless and hopeless there. And so I sometimes use these stories where people have recovered, have shown that they can recover using a variety of techniques that I talk about, and it is possible. And these are some of the websites in the UK and in the US which do bring about a lot of these stories about how sometimes changing the way you think about it can also help in making the right decisions forward. But you're welcome to check these out. I don't have any, I've worked with all of these organizations and spoken to the guys who've created it. So I feel reassured in what they do, but you're welcome to look through it and find something that resonates with you. So in summary, thank you for listening to me. I think pain in EDS is a very, very complex phenomenon. I don't deny that these are just simple, quick fixes there. What I've done, and I just offer this as a freebie to all the patients as well, just a compilation of variety of other resources and techniques and things that you want to do. If you're interested, you can use the QR code on the screen, check it out. It'll ask you for a little bit of feedback and maybe a bit of, I'm interested to know whether this talk has landed well with you. What else would you have liked to know? Just helps me create more videos for my YouTube channel as well, which is appropriate. I'm growing that. So that's why I asked this. And if you can give that as a feedback, then you will get a free download of all the other resources that might help you in your pain journey in there. They're not specific to EDS alone, but hopefully this has been helpful to you. Thank you for listening to me, and I'm open for any Q&A.
Hi, Dr. Ravindran. Thank you so much. Look, I mean, just tons of information in there, and some really interesting stuff around the medicinal cannabis. I have, as you can imagine, quite a few questions, and I'm going to kind of try to topically group them if I can. What are your thoughts on hemp?
So hemp in itself is almost, for all practical purposes, a very low a plant which has got in itself, unless until now I understand there are some industrial hemp versions where they have managed to increase the amount of CBD in them. But for traditional purposes, hemp does not have that amount of the cannabinoid volume in there. In the UK, my understanding is that it sits in that space of natural products that are available there. People are trying to use hemp oil to get concentrations that are stronger. In reality, from a healthcare professional perspective, we don't get really taught about or learn about it enough to give good, valuable advice to say these hemp preparations are useful, these are not, these have this much percentage. And I think that's where the challenge often lies. So when I was preparing for this talk, I had a look at it and I realized there's so much that I can't really be very firm in saying this is what I know and this is what I believe in, because my understanding, like even the cannabis plant about 10 years ago, the plant itself would have only the ability at the most 10% THC. Beyond that, it used to be called skunk and was available on the street. Now, the cannabis plant itself, due to a variety of inbreeding and cultivars and variety of change, you can actually improve the concentration to get up to 20-25% of THC in the plant itself. So that is, from a botanical and from an agricultural perspective, you can actually have real improvement in the hybrid nature and the concentration of these products, chemicals within the plant. So hemp also could be concentrated in such a way, and that means that it has potential, but I don't have the confidence to comment on and saying this kind of hemp is all right. In the normal proportion, I think hemp oil, hemp preparations, hemp-related products are absolutely fine. And for a big period of time when cannabis was stigmatized during the 60s to 90s, hemp production, jute in India, all of those were the staples of how people got smaller doses of medications of CBD.
Lovely, thank you. I've had lots of private messages from people about the fact that they are taking prescribed CBD, medicinal cannabis, all sorts of things. Some people on it for a year, 4 years, that's been a whole thing, and all saying that it's dramatically improved their pain levels and quality of life. So there's lots of feedback coming in about that. So there's sort of two questions here. How does someone find the right cannabis strain that is energizing and doesn't make fatigue worse? And also, if the smell of cannabis, just smelling cannabis makes me feel sick, will it have the same effect if I take it?
Very interesting point. So just as a bit of a disclaimer there, so for the last maybe 6 to 9 months, I've become part of a private clinic here in the local area called Synthesis Clinic. We are essentially looking after patients who have got cancer or who are cancer survivors, or where there's a family history of cancer. That's the group of patients we're looking at, and we are going to be having sort of a medical cannabis prescribing arm there. And these are all the questions you asked, Nikki, are essentially the same things that are relevant. In fact, even more so in patients who have a history of cancer or cancer survivors, because their taste and smell will have been highly sensitized due to chemotherapy and other immunotherapy and those things. And what we are realizing is that there is a workaround for all of these things there. There is now that I've put my foot into that industry there and understood it, there are now options to look at. So for example, tinctures or oils can be done as ways of taking the smell out there. So you don't have to have the whole flower. You don't have to have the vapes. And a lot of times it's the terpenes, it's the extra entourage chemicals which may be adding to the smell part. And that is again modifiable or completely eliminated when you go on to certain vapes or when you go on to certain oils, which actually have a bit of flexibility. So the vapes can be for immediate use, the oils can be for slightly prolonged use. And my view is that that strain discussion is something that needs to be done at a personal one-to-one level. It's possible that we can find, there's this broad thing that the cannabis indica and the cannabis sativa are the two things. One of them is more for relaxation, the other one is for more for energizing. But these days, the products that are coming on, the people who are making these plants and growing it in different parts of the world, and the things that are coming into the UK, they're almost cultivars and they're hybrids. So actually, it's about you discussing with the particular supplier slash clinician to say, is this something that's likely to give me a bit of energy but not make my fatigue worse? And then you start off. And as I said, the principle is start with the lowest preparation, start with preferably a CBD only with the lowest THC, and then work with your clinician to gradually increase the amount of THC so that you can get the balance where you get an improvement in energy that doesn't make your fatigue or your pain, rather improves your pain, but doesn't make your fatigue any worse. It's titratable, it's doable, and right now, unfortunately, it is a bit of Wild West in saying that one clinic does it better than the other. That's why I made one sort of neutral suggestion of look at medbud.wiki.
Yeah, lovely. Thank you. Any tips on talking or what to say, the words to use when you're talking to your GP or your consultant about your pain? To sort of get that across to them. One of the things we hear at support group meetings all the time, and I sort of repeat, I've had a pound for every time I've repeated it, I could retire. But one of the things I always say to people with who have chronic pain is, you kind of get used to your pain. So when people say to you, well, what's your pain level today between 1 and 10, they kind of go, yeah, well, it's about 4 or 5 today. But actually, for a lot of people, for most people without chronic pain, that would be an 8. And I think sometimes we don't tell them. We can be a bit British about it, or for want of a better term, but a bit sort of like, well, I won't tell you quite how bad it is. So I think for me, there's always that kind of be truthful, tell them how bad it is. But can you recommend anything they should say or could take with them to try and back up their case?
So thank you for bringing that up, Nikki, actually. So now a lot of organizations have taken that on board. So for example, Pain Concern has got a pain navigator toolkit, which you can download for free from their website in Scotland. Live Well with Pain is another website which has got some resources and information for patients where you can download a document and it actually says what do you need to talk about when you're going to go to your GP or your healthcare professional or even your pain specialist. How can you categorically almost categorize the information of what you've tried, what you've not tried, what you're looking for, and be prepared about it and help you document it in a streamlined fashion and then that becomes the information you take to your GP or to your consultant, and you put it in there. So I think on the top of my head, these are two organizations I know who have recognized the challenge that sometimes people with pain, for example, when you have hypermobility and you've got, for example, neurodivergence and you've got a bit of anxiety, when you're in a hospital setting, I think what we don't know, and this is very personal to me as someone who wants to talk about trauma-informed care, we do not know what journeys our patients have gone when they are going to a pain clinic. They might feel more anxious. It might bring them memories of a time that they were uncomfortable in a hospital setting for some other reason. So all of those thoughts and worries and concerns and memories can cloud them when they are sitting in a pain clinic waiting for half an hour, 40 minutes, and then they get this 10 minutes in a GP practice, or 20 minutes or 25 minutes in a consultant with a specialist care or a nurse or a physio, and everything goes out of the window because the consultant or physio or the nurse or the GP might have their 3, 4 questions to ask and actually put my patient off their starting point. And so ultimately you come out thinking, oh my God, these are things I should have asked or forgot to ask or told to ask. And I think this is a genuine problem that has been recognized by these two organizations, at least, who will say, okay, can you just categorically document all of this in your free time when you're ready, getting ready for the appointment, and take this with you and show it to your GP. And so that it's already clear there, what is it you want, what is it you're looking for, what kind of information there. And I saw one of the questions that came up in the chat about somebody saying, can you talk about medical cannabis to your chronic pain team? And no. And the likelihood, and I hope I'm wrong, but the likelihood is that right now 90% of chronic pain teams, because medical cannabis is right now not prescribable in the NHS via the GP or even by the chronic pain team, the awareness of this is not going to be there. So most people will say, we can't prescribe it or we won't know about it to this extent. Go and check out some site or check out a couple of private clinics that they might be aware of.
Lovely, thank you. I just wanted to check the first one you said, the Scott one. Was that the Pain Association?
No, it's called Pain Concern.
Pain Concern, thank you.
It's called their navigator tool, I think, which is some kind of a PDF you can download and fill in.
Pain Concern. Sorry, I'm typing it all into the chat as you're saying it. Lovely. Where was my next question? TENS machines. What are your thoughts on TENS machines and how effective can they be?
Very interesting. Thank you for that as well. So I am a general fan of TENS machines, partly because they are safe, they are cheap, they can be quite effective in a small proportion of patients. And at worst, if people have tried it and it doesn't benefit, they are out of pocket by maybe 30 to 50 pounds or out of pocket without any harm to their body. So that's kind of my rationale for saying why I like them. But I'm very understanding that the evidence for it has not been great over the years. How many ever studies have been done? We've never been able to pinpoint a group of patients they work consistently well in or what they do. What do? They have two parts there. One is the patch itself. When it comes to the sticky pad, they might be giving a direct counter irritant effect. The kind of electrical signals you feel will be providing a bit of counter irritation or a counter signaling, which is whether that's a pulse or a burst or whatever. And that will just momentarily confuse the spinal cord. So it might just prefer this pulsing signal rather than the pain signal that comes from a infection or not infection, but injury or spasm or something there. The second is it can locally agitate the circulation, so it improves blood flow and helps muscles relax. So those are the two reasons people use TENS machines, and I suggested there. But as I said, the evidence for it working effectively in everyone isn't great. What has now come through in the last few years is this concept of vagus stimulation. Can we stimulate the vagus nerve? And there are now studies looking at the concept of fatigue management in hypermobility, in chronic fatigue syndrome, in fibromyalgia, in long COVID, using the TENS machine, which has got a auricular clip, so a ear clip. And if you have a TENS machine with that kind of ear clip attachment, you could then attach the ear clips to this part of the ear, one clip into the outer part of the ear, and one clip onto the more knobbly inner part of the ear. And the studies are ongoing to say that if you use auricular TENS machine, you're actually stimulating the vagus nerve, and vagus nerve modulation is a way of altering the signaling within the nervous system and the vagus and the autonomic system. So it could be used as a treatment option for fatigue, for some kinds of dysautonomia. And that is where the interest in TENS machines is again come up. So I now suggest patients to say, look, for this pain where you're having muscle spasm, where you're having muscle tension, if you want something that's not about the drugs, which is cheap and cheerful to try, explore a TENS machine, try it for 2 to 3 months, use it for up to 1 to 2 hours, 2 to 3 times a day. You're trying to enhance the neuroplasticity. You're trying to get those new nerve circuits to fire differently, and you're changing nociception. So it's not about using it for just 1 week and saying it didn't work, but to consistently use it for a 2 to 3 month period and have the ear clip option so you can interchange between using it on certain painful areas to also using the vagus nerve for the dysautonomia and fatigue features as well. So I'm trying to say, is this an option that does more than what we've traditionally used it for?
And that's really interesting as well, because I often hear the TENS machine doesn't work for me, but I wonder whether it's because, exactly as you just explained, they've kind of put it onto a painful area, tried it, and it hasn't made. But like you say, you need to build that up and use it over a period of time. So that's really really useful info. Thank you. Going back to the old medicinal cannabis again, we've had a few people, as I say, saying, a lot of people saying that they get it. What proof of having EDS or HEDS or HSD would they have to show? Because we know it's very hard to get an actual diagnosis. How could they prove that they need it?
It's actually not the question of a diagnosis of HEDS makes it easier for cannabis. That's not at all. In fact, right now, the NICE guidelines, or for that matter, as I showed you on the slide there, when I looked for medical cannabis studies in hypermobile patients, we don't have any good quality studies that are ongoing. The first one that came in March of this year was a registry data from the UK Cannabis Group, where they were able to look at 161 patients and actually say, yes, it does work well in hypermobile patients. Clearly, what right now a lot of people on this chat are saying, clearly it works well. But it's not that you need a diagnosis of EDS to get medical cannabis there. I think the real challenge is you don't have a clinician or a GP right now who has enough knowledge about medical cannabis to give a safe prescribing, and you're having to do a lot of the work yourself in finding it there. And that's where I think medbud.wiki is a good place for you to start. And I think if you're going to have this history of cancer or cancer survivor or family history there, then that is again an option that I would suggest to the synthesis part. But these are all, everything is sitting in the private sector right now, and that's the challenge. I think over the next 3 to 4, 5 years, as we get more better quality studies or better registry data, real world data, we may have enough to actually let NICE look at the evidence and say, yes, for more groups of people like this, for example, EDS, cannabis should be thought of as earlier in the drug medication life cycle than where it is now.
Lovely, thank you. Are there good results for pain and fatigue with bioresonance?
So it's a field that I'm still looking at in terms of sound energy there. Maybe what I'd be interested to find out from the person who's asked the question is, what frequencies, what sound frequencies, are they related to water as well? Is that in relation to that they're asking? Because both light and sound are now being looked at as ways of, but ultimately, what are these, what we call complementary or adjunct therapies doing? The evidence that is coming through, if I have to put on my scientific hat on, or the Western lens hat on, so I can also put on my Eastern Indian philosophical Ayurvedic traditions on hat on and say at a wider level how we are all connected by different energies, And so light, sound, all of these are energies that will interact with the energies we have, and that will have a certain resonance. And when that resonance happens, there will be alignment and the nervous system will feel safe. So that is the spiritual Eastern side of the argument that says how bioresonance works. From a Western medical, uh, looking into and saying what's happening when sound energies or music or noise comes through, is that you are harnessing the ability of the vagus nerve. You are changing the way firing happens within the nervous system, specifically the vagus nerve. More likely, some cortices, some changes in the reticular activity in the back of the brain in certain areas where these being changed. So at a medical level, you're altering the neural circuits. You're possibly providing some level of safety for the immune system to start turning itself down, inflammatory chemicals to come down. And that is how probably bioresonance, sound energy, photobiomodulation, which is light energy, crystals, all of these energy field therapies are probably being made to work in that space of changing neural circuitry and inducing safety in a different way. That is kind of where I'd be looking at it from a Western lens on.
Yeah. I'm just going to do two more questions. We could be here until tomorrow, but I've got to, because again, we've had this question asked a few different ways. I've got two more. The first was, what are your thoughts on sort of, so things like PTSD, childhood trauma, that kind of thing, when you become very hypervigilant, and the impact that can have on your pain? Is there can that be helped with the seeing a psychiatrist for the trauma? Although we're not obviously talking about psychiatrists for talking about your pain, but does that help with the trauma, and therefore can that help with the pain?
Absolutely. And I said it doesn't have to be psychiatrist, particularly, or mental health there. Absolutely, beyond doubt, Nikki. This is where the unification of the mind and body is come through, and there are so many people like me bringing this conversation thing together. This is not about trauma and pain separately. The circuits are the same. The trauma circuits, the circuits that get a little changed, do so because when you have complex PTSD or you've had trauma, a variety of kind, childhood trauma, those nervous and immune systems have adapted during childhood and they are protective. They have adapted absolutely to protect the child at the time, to work around and survive through the trauma they've been facing. Their immune systems become and tell the nervous systems to be more hypervigilant, because if you think about it, hypervigilance and being extremely vigilant for all the various stimuli that come at you from different sides, because you don't know where danger is coming from. And unfortunately, for many cases of childhood trauma, if the danger is actually someone in your household, then that is a really unpredictable level of threat that the nervous and immune system has to cope, adapt, understand, and help you survive into adulthood. So that leaves you with a relatively hypervigilant and nervous and immune system entering into adulthood, which means that it can be that a relatively trivial twisting or a movement or some kind of smaller injury, which in another person without that adversity or childhood or complex changes may have become normal quickly or healed quickly, and the neural circuits don't have to be wired up too much. In someone who's got that PTSD or vulnerability, that relatively same injury or surgery or some form of trauma can trigger the entire dormant circuits to say, yep, this is what I think I have to be afraid for. It happened 20 years ago in another context. I'm not taking a chance this time. I'm just going to go into full shutdown. I'm going to go the muscles to go into spasm. I'm going to make the nerves extremely hypersensitive. So the whole area is going to feel sharp, pins and needles, burning, throbbing, touching, and I won't let anyone touch it anymore because that's my preferred safety option. I'd rather have you safe and secure and protected even if that means you don't go out anywhere, don't do anything, walk less, move less. And that is the way persistent pain can present in the context of complex PTSD or childhood trauma. And that's where the research is now coming together, because the neural circuits are the same, whether it's for mood or memory or trauma or pain, they're all overlapping with each other. And so treatments for it can be done together. The only thing to realize is sometimes some of the psychiatric treatments, for example, like EMDR, we think that's a good treatment for trauma. But when you are doing EMDR, and I think just for the people who are listening to this talk, maybe you don't know, EMDR stands for eye movement desensitization and reprocessing. So effectively, what the trauma specialist or the therapist working with you is saying is that trauma could be contributing to your mental health symptoms. We are going to help you reprocess the signals and process it in such a way that the body, rather the mind, processes the trauma. What sometimes the mental health therapists don't take into account is that when your mind is reliving those memories and processing it, your fight and flight system has kicked into place, your body has released, and your mind has instructed the hormone system, because the nervous and immune system, I've been talking at that level, but the nervous and immune system operationalizes things through the hormone system, through the female sex hormones, through testosterone, through growth hormone, through adrenaline, through cortisol. When these hormones are just released, so thyroid hormones, when these hormones are released as a way of reacting to those memories, it's not just the eye movement that is reprocessing it. Those chemicals enter into the bloodstream and they end up going to the rest of the body. So I've had a few patients over time who suddenly say that, well, actually, I was going through EMDR, my pain got worse, and so my trauma therapist told me, well, go to the pain clinic and check it out. And I actually will be able to correlate and say, your pain got worse as you're doing the EMDR sessions. There was no injury. There's no surgery. I've done a scan for you. Look at it. Your scans are all the same as they were. But this is the science. This is the science that your pain can actually feel worse when you're starting through some of the trauma therapy sessions. So be aware. Do not be afraid. This is what you need to do to continue to protect and calm the nervous and immune system as you do those sessions. But just be aware of how we want to be treating those symptoms when they come through.
So fascinating. Thank you. I could talk on this for hours. It's just so interesting. Last question. I know there's tons and tons coming through, and I do apologize, but I'm going to finish the last question. Whole body cryotherapy, which I think is that the thing where you stand in the freezing tank? What are your thoughts on that?
So you can come at it from three things. And I think in the chat here, I saw a few questions around oxygen deprivation, oxygen therapy tanks,
Okay.
Sensory deprivation tanks, cryotherapy. There are two parts to this. One is, what is the actual treatment doing? The second, again, I come back to it. How is this considered safe for the nervous and immune system? And that's really crucial and important, is each time you undertake a new technique, your nervous and immune system is automatically questioning, is this going to be safe or not? So as long as, so at a meta level, I'd say that any of these techniques, I have had patients with hypermobility or other persistent pain or fatigue conditions going through cryotherapy, going through sensory deprivation tanks, or talking about it in the US context. In the UK, I'm not aware that there's a separate sensory deprivation chamber available anywhere, unless you're a sports athlete, maybe. But then there are these flotation tanks, which do reduce a lot of sensory symptoms right down, because you're just floating quietly in a small pod by yourself. You've got oxygen therapy tanks, which are slightly increased levels of oxygen. The first part of whether these techniques are going to be successful is whether you have received enough safety stimuli around them. Have you been told by someone you trust to try out this? Have you been told by somebody who is passionate and has been receiving the benefit, who's told you about it? All of those are signals to your brain and your nervous system, which is looking out for you all the time to say, is this a threat? Is this something I'm willing to try? Will it make me worse or not? So that's the first part of whether the procedure will help or not. Even as you may call it a placebo effect, but again, I would like to tell all your listeners and viewers today is don't think of the placebo effect as something that's just a sugar pill or something. We have now got evidence that placebo circuits exist. So even if you told somebody that this is a placebo, your neural circuits are looking out to protect you. They will look at meaning and expectation and change. So now we are saying the placebo effect should not be called the placebo effect. It's the meaning response. It's what it means to you, your nervous system, and your immune system when you receive an information. So in IBS treatment, for example, in the US, they have done studies where they've actually told patients, here is a placebo. It's open label placebo. They're actually telling the patient, this is a placebo pill. And still 30% of the patients got fantastic benefit from IBS pain, even though they knew they were taking a placebo. So in that context, even if you thought oxygen chambers and sensory deprivation, all the stuff may be placebo, the fact that you've been told in the right context and what it means to you can make a difference. At a biological level, what does it actually do? Cryotherapy, for example, when you induce extreme cold, your body produces a reaction to it. It induces a protein called heat shock proteins. And these proteins are actually acting as anti-inflammatory cytokines. They act as anti-inflammatory chemicals. So cold is a way of giving, and that's why athletes go for cold bath after their major sporting events, because cold in its extreme state induces a state of releasing these anti-inflammatory cytokines which act as immediate pain control measures. So whole body cryotherapy at its extreme is a way of inducing a large amount of anti-inflammatory chemical release which can reduce the symptoms for a bit. How long it lasts for, I don't think the studies have been done, certainly not even in persistent pain, and I'm not aware of anything in the hypermobility area, so I can't comment on how long a benefit lasts for. Similarly, with oxygen therapy tanks, hyperbaric chambers, sensory deprivation chambers, my view is that these are all ways of bringing about threat. If you can be assured and give the first bit of safety, that's good. The second bit is when you actually do the treatment, it will induce some safety elements to your nervous and immune system. As your immune system turns itself down, as some of those, and I go into it in other talks of mine where I talk about particular kind of immune cells in the brain, which then switch to a more gentle, compassionate stage, which induce healing, which allow for good neural circuits to flow, which allows for good resumption of neural traffic. In that stage, once neural traffic resumes to normal levels, you notice an improvement in pain, reduction in fatigue, improvement in memory, brain fog reduction, muscle spasm relaxing. And I think that is how these other techniques are bringing about an improvement in pain management and quality of life. But they are not one-off treatments. So that means you will have to factor in how much is it going to cost, how sustainable it is, how far do you have to travel to get these things, how much are you going to pay each time. And if these are things that you have to look at for a foreseeable future, what are the things you need to do alongside this to ensure that you're calming your nervous and immune system down on an ongoing daily basis, rather than saying once a week I'll go and spend 150 quid on a sensory deprivation thing and you're doing nothing during the week.
Lovely. Thank you so much, Dr. Ravindran. That has been absolutely fascinating, and I really appreciate the very thorough answers as well to a lot of these questions. I think we'll be having you back fairly soon, because I can see already people are saying we need more of this. So I will definitely be booking you in again. But thank you so much for such an informative talk today.